Hi, my name is Thao Nguyen. I'm the pharmacy student from the class of 2021. So today I'm going to talk about the use of proton pump inhibitors in children and its relationship to the risk of fracture. So by the end of my presentation, you'll be able to evaluate the association of the PPI use and the fracture risk, and also be able to apply the safe practice for acid suppression therapy. Now let's go ahead and start it. Proton pump inhibitor is one of the treatment options for acid suppression therapy in children. The mechanism of action is by inhibiting the proton pump, which will suppress the secretion of gastric acid. The common approved indications for children including GERD and erosive esophagitis with a duration of treatment of 8 weeks or less. The listed drugs here are the proton pump inhibitor can be used in children. Esomeprazole or Nexium is approved by the FDA for use in infants of 1 month or older, while the protonic pantoprazole is only approved for use in children of 5 years and older. The other agents of proton pump inhibitors such as the Prilosec omeprazole, Acifex rabeprazole, and Brevacid lansoprazole are approved for children of 1 year and older. So we will look at two studies today. The first one is the early acid suppression therapy exposure and the fracture in young children. This study is published in the Pediatric Journal of 2019. The study objective is to evaluate the relationship between acid suppression therapy use that include the use of the A2RA and or the proton pump inhibitor in the infant or older children with the risk of fracture. It also looks closely at the impact of the therapy duration and the starting age on the fracture risk. This study is a retrospective cohort. The data, such as the day supply and the refills of all the acid suppression therapy prescription, was extracted from the civilian and military outpatient pharmacy records. The participants were followed up to 5 years after the acid suppression therapy initiation. Inclusion criteria includes children in military health system who had received continuous military health system care for at least the first 2 years of life. On the other hand, children who were diagnosed with osteogenesis imperfecta, cholestasis, child maltreatment, or birth hospitalization of 7 days or longer were excluded from the study, because these conditions could impact the bone growth of the children, which could have an influence on the result. The study primary outcome is to evaluate relationship of the use of acid suppression therapy in first year of life and the fracture risk, while the secondary outcomes we will look at the relationship of the duration and the starting age for the therapy with the risk of fracture in children. As for the statistical analysis, the study used the Cox proportional hazard ratio with the adjustment factors that can affect the result. Such factor includes the gender, prematurity, low birth weight, previous fractures, seizure medication, and obesity. Now let's move on to the result. So this study includes more than 850,000 children, of which 11% of them were prescribed with acid suppression therapy in the first year of life. To look more closely, of those on acid suppression therapy, 73% of them were prescribed with A2RA, 9% on proton pump inhibitor, and 18% on both the PPI and the A2RA. For the primary outcome, it showed that the use of PPI used in children less than 1 year old is statistically significant in increasing the risk of fracture. More specifically, it will have 1.23 times higher risk of fracture comparing to the group not on the acid suppression therapy. While the combination of the proton pump inhibitor with the A2RA poses a higher fracture risk comparing to the PPI alone, with the 1.31 times as slightly. On the other hand, the A2RA group did not show to have significantly increased the risk of fracture in children. When looking at the duration of acid suppression therapy in fracture risk, it was noted that the higher risk was associated with longer duration for all acid suppression therapy groups. Specifically, the risk is significantly increased after 2 to 4 month use. However, even though H2RA has increased risk with longer the duration, H2RA still tend to be at a lower risk comparing to the PPI group and the PPI with the H2RA. For such that when the therapy duration for lasting for more than 4 months, H2RA will have 1.22 times higher risk. Comparing to the PPI, it will be about 1.41 times higher and 1.31 to 1.5 times higher in the combination groups. On the other hand, when looking at the starting age for the acid suppression therapy in the proton pump inhibitor group, it showed that the younger the patient, the higher the fracture risk. You can see the trend of slightly decrease in the risk as the therapy was started in the older age group. On the contrary, in the combination group, the results showed to be at a higher risk when the therapy was started in children younger than 6 months or older than 1 year of age. However, the risk appeared to remain higher comparing to the proton pump inhibitor use alone across all age groups. And for the H2RA group, it did not show to be significantly increase the risk of fracture regardless of their starting age. Alright, so in the conclusion, we could conclude that the use of the proton pump inhibitor alone or in combination with the H2RA in children less than 1 year of age was associated with small but significantly increased risk of childhood fracture. And the longer duration of acid suppression therapy and earlier initiation may amplify the fracture risk. So we'll look at the second study. This is an association between the proton pump inhibitor use and risk of fracture in children. This was published in the JAMA Pediatric of 2020. So the study objective is to evaluate the association between the PPI use and the risk of fracture in children. This is a cohort study using the Swedish nationwide registers. The study matched the children using the PPI with those who were not on the 1-to-1 ratio, using the propensity score and age group with 2-year band. This study started from July 2006 to the end of December 2016. The participant will be followed up from the index date, which is the date when the participant will first start taking the PPI. So it will be from the index date until the first diagnosis of fracture, emigration, death, age 18 years, 5 years of follow-up, or the end of study period, whichever occurs first. Now, the propensity score they will look at will be based on the baseline characteristic like the age, gender, location, parental education, income, comorbidity, healthcare use, number of drug use, etc. So the study will include the participants who were less than 18 years of age and had their first PPI use initiated during the study period. It will exclude all the participants who had cancer, organ transplant, congenital skeletal malformation, birth trauma associated fracture, severe liver failure, fracture, and fracture complication. The study primary outcome is to evaluate the relationship of the use of PPI and the fracture risk, while the secondary outcome include the relationship of risk fracture with the duration of PPI and the individual PPI drug, such as the esomeprazole, omeprazole, lansoprazole, and pantoprazole. As for the statistical analysis, the study used cost-proportional hazard regression models to assess the relationship between the PPI use and the risk of fracture, and the Poisson models is to estimate the incidence rate. So for the study result, the study include more than 200 30,000 children with the mean age of 12 years. There were 61.1% who were female, and the follow-up time was about 2 years in the proton pump inhibitor group and the control groups. For the primary outcome, you can see that the PPI use increased the risk of fracture comparing to the group who did not use the PPI, with the ratio of 1.11 times higher. For the incident rate, you can see that there were 20.2 comparing to the group comparing to the 18.3 of the children who did not use the PPI. So now this means that out of 1,000 persons who on the PPI, there will be 20 cases of children having the fracture. And there are more fracture occurring on the upper limb and the lower limb and the other fracture comparing to the number of cases seen in the head and spine fractures. When looking at the PPI use and the fracture risk, it was noted that the higher risk was associated with longer duration of PPI use. You can see that it was increasing from 1.08 times for less than 1 month use to 1.14 times at 1 month use to less than a year, and 1.34 times for use of longer than 1 year. And you can see that the incident rate is also increasing as well, from 19.6 to 24.5 after 1 year use. Now, when looking at the relationship of risk for any fracture with the individual PPI drugs, omeprazole showed to have statistically significant association with the fracture risk comparing to other agents like esomeprazole, lansoprazole, and pantoprazole, with the ratio risk of 1.08 times higher and the incident rate of 19.5. However, if you're looking at the number of participants who were prescribing for omeprazole, you can see there were more than 90,000 cases, while the other agents, they have less than 20,000 prescriptions prescribed. Therefore, it could be one of the the number of cases could also impact on the results as well. In the conclusion, we can conclude that PPI use was associated with increased risk of fracture in children, longer duration, and the use of omeprazole may increase the risk of fracture in children. In general, the following is what I believe to be safe practice for acid suppression therapy. First, use the lowest effective dose of PPI for shortest duration of time. Most of the time, it will be less than 8 weeks period. Avoid the combination of the proton pump inhibitor and the H2RA because this combination shows to have a higher risk of fracture comparing to the H2RA and the PPI use alone. Choose the H2RA if appropriate for the younger population over the proton pump inhibitor, monitoring for fracture events and calcium, and in case of the fracture occur, monitor for calcium and vitamin D level.